We'll give it another minute and then we'll get started.
That you did it?
So there's something in the Q&A. All right.
Yeah, it says, I want to talk. This is beautiful.
Oh, perfect. All right. 1 second here. Okay. So hello, everybody. My name is Zoe. I'll be moderating tonight's session. Tonight's program is going to be recorded and uploaded to AAEM's Women in Emergency Medicine website. It's meant to be interactive, so please use the Q&A function if you have any questions or comments. We welcome and encourage any participation. Today, I have the privilege to introduce our panelists, Dr. Motov. As I introduce you, please come on the screen. You're on screen. Dr. Motov is an emergency medicine physician participating in practicing in the Department of Emergency Medicine at, if I mess up this name, I'm sorry. Maimonides Medical Center in Brooklyn, New York. He graduated from the Medical Academy of Latvia and completed his EM residency at the same medical center that he's at now. Dr. Motov is a research director who is passionate about safe and effective pain management in the ED. He has numerous publications on the subject of opioid alternatives in pain management and is actively involved in growing his body of work both nationally and globally. So Dr. Motov, I'll let you take it from here.
Wonderful. Thank you so much, Zoe and Jordan, for amazing introduction and more importantly, for opportunity to be here today. And of course, I want to thank Academy and Women in Emergency Medicine section of the American Academy of Emergency Medicine. So let's get right to it. Let's talk about opioid epidemic, but I have a twist. So as we all know, and for those who don't know, I'm just going to refresh your memory. The country, as everybody like to use word, in the midst of opioid epidemic. Well, we're living in, and unfortunately, there seems to be no way out of it. What started almost 25 years ago as non-malicious but unsupervised, fairly liberal opioid prescribing for primarily patients suffering from chronic non-cancer pain resulted in a public health tragedy known as an opioid crisis, with its opioid misuse, abuse, diversion, overdose, and death, and development of an opioid use disorders. And numbers, unfortunately, are fairly depressing. Between 1996 and 2021, slightly over 900,000 people died from unintentional opioid overdose. And at the same time, over 4 million people are suffering from an opioid use disorder, formerly known as an opioid addiction. So emergency medicine, as a specialty, firsthand experienced the unregulated opioid prescribing, harm associated with opioid prescribing, and of course, consequence of opioid epidemic. Emergency physicians are uniquely positioned to provide safe and effective pain management by actually utilizing opioids and balancing this safe prescribing with prevention and hopefully development of opioid misuse and opioid use disorder. And the way it comes to it, there's the 3 things that the emergency physician can do. We can do, first thing is a prevention. And the rule is we're trying to keep opioid naive patients opioid naive, not by denying them an opioid, by actually engaging them in shared decision making and figuring out what would be the best analgesic modality for this type of patients. And at sometimes it might not be necessarily an opioid. Second, harm reduction. For those patients who are opioid dependent, have evidence of opioid misuse, we can offer harm reduction, like take home naloxone, right? And ultimately, once we identify patients who are suffering from an opioid use disorder, we can offer them life-saving medication and life-improving medication known as buprenorphine, medication for opioid use disorders. But what I want to talk today, I want to focus on it, on safe opioid prescribing practices as a part of the first thing that we can do towards curbing and reducing this insane opioid epidemic. Back into the opioid epidemic, when in late 2000s, United States realized that we're really in a pickle here because of we just having people die right and left, and we need to figure something out. The government and then state level and then hospitals and then departments all put together a set of guidelines, mandatory training, annual compliance testing, created prescription drug monitoring program with all particular thing in mind: to substitute, to diminish, to reduce, to abolish, to ban, to substitute opioid whatsoever across all the specialties in the country. And as a practicing clinician in the emergency department, I'm always interested to see whether or not it helped. Well, look at this number. Between 2011 to 2020, numbers of opioid prescribing dropped by 44%. Sounds like time to celebrate. And at the same time, the clicks when it comes to accessing prescription drug monitoring program went up from 61 to 910. It's almost like 700% increase. Really time to celebrate. But once again, I'm being cautious or optimistically cautious. And the question is, numbers are phenomenal. But from a deep perspective, I want to know, do these numbers translate into reduction in morbidity and in our case, mortality? Well, let's take a look. On the bottom of the slide, this is the very beautiful number of reduction opioid prescribing through a decade between 2010 and 2021. On the top portion of the slide, number of deaths related to opioids. So here is we have an issue. They're not congruent, they go in different directions. Number of opioid prescriptions are going down, but number of deaths are going up. So what is the disconnect? I'm going to give you a tiny little historical perspective. I have two. This is number one. Between 1999 and 2010, opioid deaths were primarily related to prescription opioids, of which oxycodone and oxycodone-related products were contributing to about 85 to 90% of those deaths. When government finally decided to crack down on those crazy prescribing practices, pill mills and what have you, and made oxycodone rather more expensive than it was before, those subset of people who've become opioid dependent or start misusing oxycodone, particularly, turned into heroin. It was cheaper. And between 2011 and 2013 or 14, death related to opioids were primarily attributed to heroin overdose. And then in 2014-15, illegally manufactured or synthetic fentanyl, including tramadol, unfortunately, flood the market in the United States and some other parts of the world, and primarily now responsible for the opioid death. So here is our opioid paradox. Number of prescriptions, which are in black, are going down. Number of deaths, which are in red, are going up. So look, I cannot really be on the street and hunting people and stop them from using heroin. I cannot prevent influx of illegal manufactured fentanyl from China, Latin America, other countries into the United States. I just can't. But what I can do is I can still focus on prescription opioids, or opioid prescribing practices in the ED and at discharge. Between March 2021 and February 2022, there were 104,000 deaths related to opioids, 67,000 of those related to illegally manufactured fentanyls, about 20 to heroin, and some between 20 to 23,000 related to prescription opioids. It's still a big number, 23,000. And that's, once again, that's what we're going to talk about it today. Now, here is the twist. In my humble opinion, that unilateral, that blindsided point that we need to ban, abolish, substitute, and reduce opioid prescribing is partially correct. But there's a bigger fish we need to catch. And this is a quality of opioid prescribing. Don't get me wrong, I still believe that nobody should be getting 30 Percocets, 30 oxycodone, acetaminophen combination for splinter in their pinky toe and 3 refills when they go home with. No. But what's important is, in addition to that number of opioids pills we prescribe at discharge from the emergency department, it's actually important to know which particular opioid we're prescribing. I'm going to pause here for a second. So I say quality of opioids. What are you talking about? Well, let me give you my second favorite historic perspective. I want to take you way back, 3400 BC. Sumerians. This is actually the first tribe in history who discovered a very remediative and recreational properties of poppy seeds. There's a picture of it's a poppy seed of opium. And what they did was they're able to extract them, and they felt extremely joyful. They felt very, very helpful when they consumed those poppy seeds. And they called this plant of joy. 2200 BC, ancient Greeks managed to make a different variety of drinks out of the poppy seeds. And by consuming those, they turned themselves to this trance-like state. They were tranquil, they were elated, they were happy. Life was beautiful. And they called this magician's remedy. 1800 BC, 1600 BC rather, Afghani Pakistani tribes had this daily or nightly tea drinking party. Want to guess what was in the tea? poppy seed extracts, and they felt elated, they felt happy, all the worries went away, and they were just chilling. Now, 1500 AC, Paracelsus, very famous scientist, clearly stated that laudanum, which was a mix of opium extract, it's something to be praised for. Just on a side note, 1500 AC was the worst year when France as a country suffered from the opioid epidemic. And to wrap my historical perspective, this is my favorite artist, Amedeo Modigliani, who, while living in France, was frequently visiting this beautiful establishment titled Opium Den, that he was inhaling opium extracts and putting himself into this trance-like state, or I'd say comatose state, but everything was beautiful, everything was perfect. So if I had a chance to see you all in person, let's say this concentration person, my question would be, what unites all these people? Sumerians, ancient Greeks, Afghani, Pakistani, Paracelsus, and Amedeo Modigliani. And the question is, you guys ready for it? They were all getting high. What? They were all getting high. Oh, I'm sorry, it's a medical term. It's not a medical term. We're physicians, or you're about to be physicians. What's the medical term for high? They were all getting euphoric. They were experiencing euphoria. What's euphoria? It's a state of extreme or intense happiness and elation. It's a joy, self-confidence. I feel like I conquered the world. And here's the kicker. The couple of take-home points I want you to take. This is the first one. In my opinion, again, euphoria is the driving force behind an opioid epidemic. Simple example. If something tastes like crap, if I give it to you, you may not take it and probably won't take it. But if something tastes so good, some of you or some of us may want it more. Something happens with opioids. For the most people, when you take an opioid, you will take appropriate pain relief and people will just go by it. But some sort of patient who are susceptible to euphorogenic properties of opioids, they will be putting themselves on a self-perpetuated cycle of self-destruction by self-administered medication, seeking medication out on the street, and unfortunately developing opioid use disorder, and worst case scenario, overdose and die. So that's the title of my talk is today, opioids and euphoria, why it matters. I have nothing financial to disclose, and let's talk about opioids. As someone who I mentioned earlier, we talk about, I'm a PGY 22. Yeah, it pains me just to even admit this. And I've been practicing emergency medicine for 19 years. I did ear surgery before, and I've been giving opioids on a daily basis ever since. And you know what? They're effective. You know what? They do work. For the pain in the emergency department, what they need to, they're really good medication. We know how to dose them. We know what happens if you overshoot a bit. We can give patient naloxone. They're inexpensive and they're reversible. So really good armamentarium, frankly necessary for some of the painful complaints. Here's where it gets important. There is this entity in medicine called equi-analgesic conversion of opioids, which meaning if we measure all opioids against morphine, and if we properly use conversion factor, there isn't a difference when it comes to analgesia, for example, between morphine given at 10 milligram dose intravenously, or fentanyl given at 100 microgram intravenously, or hydromorphone given 1.5 milligram intravenously. There isn't any difference as long as we're under this analgesic conversion. But what do they differ in lipophilicity? So again, if I stop here, they're like, are you kidding me? You just told me you're a emergency room physician. Why are you talking about lipophilicity? Why are you taking us back to medical school? Well, I'm still in medical school and I don't even want to know about lipophilicity. Well, just hold your horses for 1 second. It's important. What is lipophilicity? Lots of fat, right? No. Lipophilicity describes or entails a speed with which a substance, chemical drug, in our case, opioid, penetrates a blood-brain barrier. Higher the lipophilicity, faster the drug penetrates blood-brain barrier. So opioids, while if we under equi-analgesic conversion may provide similar pain relief, they all differ with respect to their ability to penetrate blood-brain barrier and consequently with their lipophilicity. Once in the brain, opioids have tendencies to get into the midbrain and stimulate a great deal of mu receptors that occupy reward center, corpus callosum, nucleus accumbens, ventral tegmental area. And once those mu receptors are activated, they have tendency to activate granules filled with dopamine, and dopamine gets released into systemic circulation. Remember the nickname for dopamine? Pleasure hormone. That's what euphoria is all about. So it's a very simple pathway. Lipophilic opioid, blood-brain barrier, midbrain, mu receptors, dopamine, euphoria, everybody's happy. Dopamine is responsible for getting high. Opioid is responsible for Sumerians, Pakistani, Afghani Greeks having those tranquil-like state and reward inhalation. And dopamine is responsible for euphoria. Second take-home point: all opioids are addictive. It's a known fact. But there is a chance to figure out the one which is maybe slightly less addictive and stick to it. Because as I mentioned earlier, quantity is important, but quality, in my opinion, is probably even more important. So choose or find a balance between an opioid that can give you very good analgesic efficacy, or your patient, rather say, but at the same time will result in a less euphoria and consequently in less addiction. Let's talk about parenteral opioids. Remember, there's parenteral and there's oral. Start with parenteral. Godmother, godfather, the ancient opioid of all times is morphine. I love it. 5,000 years worth of history cannot erase it. Predictable, everybody's comfortable with it, well, at some point, and we know what happens. Brief pharmacokinetic, pharmacodynamic, again, God, what are you doing to us? History, lipophilicity, pharmacodynamic, no, I'm just kidding. So two metabolites, which should not be used in patients with renal failure, has some tendency to release histamine. This is important because if any of you, like me, practice emergency medicine, practice and have seen patients who do get to receive morphine, they have tendency sometimes to become very sweaty, very pale. Their blood pressure may drop a little bit. They feel nauseous. Some of them may even vomit. So that's partially because of histamine release. But most importantly, morphine is very hydrophilic. What does it mean? It crawls through the blood-brain barrier. It's not as fast as his counterparts. And because of it, people have this constellation of symptoms of nausea and dysphoria and sweating known as dysphoria. So morphine is rather dysphoric than euphoric. And if I have my fellow colleagues on this webinar who's been actually practicing clinical emergency medicine, I mentioned to you that I've been 20 years into it. I've yet to encounter a patient who would come to my emergency room and tell me, Doc, can I have some morphine? It just never happened. That just never happened. And partially because the negative effects of morphine, primarily associated with dysphoria, is very prominent. Now I have this soldier, which is semi-synthetic analog of morphine, hydromorphine, dilly. Evil, my nemesis. I have several aversions when it comes to opioids. I can disclose them later. This is one of them. And the fact is, it has one active metabolite. It still does release histamine, but see those pool-looking balls, number 8 and number 10. This is something good to remember. Hydromorphine is about 8 times more potent when it comes to analgesia. That's why 10 milligrams of morphine equals 1.5 milligrams of hydromorphine. Okay, but it's about 10 times more lipophilic, meaning that it flies through the blood-brain barrier significantly faster, activates those mu receptors in midbrain, releases crap load of dopamine, and what happens? Results in a very fast onset of euphorogenic or euphoria, which in susceptible subtype of patients may lead to patterns of misuse, self-escalation, request for hydromorphine by the name, and subsequently developing opioid use disorder. Studies on people with opioid use disorder, opioid dependence, or full-blown opioid use disorder clearly stated when those patients were randomized to receive intravenous hydromorphine or oral hydromorphine, or intravenous morphine or oral morphine, the rates of euphoria, reward, and taken again ratings were significantly higher in those who received hydromorphine. Similarly, studies on healthy volunteers who were randomized to receive intravenous morphine versus intravenous hydromorphine clearly stated and showed that those who received hydromorphine resulted in pleasurable body sensation, liking of the drug, and wanting to take it again and again and again. It's highly euphoric. It's highly addictive. Remember that. Medicinal fentanyl, by far one of the most lipophilic drug out of all the opioids we've known. It's like military jet. It's about 100 times more potent from an analgesia perspective, close to 600 to 800 times more lipophilic than morphine. So it just runs through the blood-brain barrier, kills everything on its way. It causes a great deal of euphoria. But there's additional parts that we need to remember. Studies in controlled environment. Why controlled? Fentanyl has a very narrow therapeutic index. Any type of miscalculation will lead to respiratory arrest and death. In controlled environment, when studies were given in a properly escalated way with monitors and physicians on a standby, likability and abuse liability of fentanyl was significantly higher than any other opioids known to human. Controlled environment. The real world pattern, unfortunately, does not support this. notion. When 700 people with opioid misuse were queried with respect to preference for particular opioids, less than 5% of those preferred fentanyl. 85% of those said we'd rather take oxycodone and hydrocodone. And the question is why? Because those on the street who are misusing opioids, and not only on the streets, they're very much aware of the narrow therapeutic index of fentanyl. They want to get high. They really don't want to die. Let's talk about oral opioids. Technically, same principle, right? Just to refresh everybody's memory, acetaminophen hydrocodone combination known as Vicodin or Norco is the most commonly used opioids out of ED and NDED, 3 times more commonly used for medicinal purposes, 3 times less used for misuse in comparison to oxycodone. Second, acetaminophen oxycodone known as a Percocet. Number 2, slightly decreasing. To my great concern, if you look on the bottom of the graph, tramadol is on the rise, and we'll talk about in a second why, and then acetaminophen, codeine, and what have you. So from analgesic perspective, there's no difference, again, between oral opioids, between, let's say, oxycodone, hydrocodone, even oral morphine, if we honor analgesic conversion. But what do they differ with? Again, lipophilicity. And remember, lipophilicity, blood-brain barrier, midbrain, mu receptors, dopamine, euphoria. I promise you by the time you're going to be perfectly able to put this vicious cycle together by the time this talk is over. Let's talk about my second nemesis, my second aversion, oxycodone. Oxycodone has a unique abilities to do certain things. 2, first, has one of the highest oral bioavailability of all opioids, some between 65 to 87%. That's a lot. So IV route gives you 100%. Oxycodone, in the best way, can get up to 87% of all oxycodone swallowed can get into the systemic circulation. That's a lot of oxycodone. But even worse, it has a disproportionately high ability to penetrate blood-brain barrier. And now if I stop, you can continue what's going to happen, right? Once opioid penetrates blood-brain barrier. So I'll shut up for a second. The reason being, animal studies showed that uptake of oxycodone in the brain is about 6 times higher in a concentration than morphine. Once in the brain, concentration of oxycodone in the brain 3 times higher than in the blood. So just imagine brain and that rewarding center just bathing in oxycodone. And the thing is, once it's there, it's very tight with mu receptors. It really doesn't want to go. And because of it, onset of euphoria is fairly prominent, and the high, the initial kick, it's so overpowering. That's why oxycodone and oxycodone-related products are very, very misuse, abuse, and diversion prone for that very intense feeling of happiness, aka euphoria. Consequently to it, if you once experienced it and you're susceptible to it, you really want to get it more and more and more. And you're going to do everything in your power, legally or illegally, to get more of a drug. And unfortunately, you have tendency sometimes to consume more than you're supposed to. And worst case scenario, you overdose and die. And best case scenario, listen to what I'm saying. And if you want then the potential to develop an opioid use disorder, best case scenario is very palpable and it's there. So oxycodone, remember. And in my opinion, we're going to talk to it should not be used as a first, frankly, second, even third line defense when it comes to oral opioids in DD and at discharge. So say no to oxycodone. Last historical perspective, 1954.
Did he freeze? Dr. Motov, you're frozen. Uh-oh. Okay, we'll give it a second to see if he gets back. Jordan, everything's frozen on your end too, right?
Yeah.
Okay. Oh, we lost him. Okay, hang tight. We'll give it a second, see if he comes back.
Oh, is he back?
Hold on. Panelist. We lost you.
Yeah, I know something happened. I'm so sorry. I
Don't
just need
worry.
one more second. I hope you pause the recording. I'm still good with timing and I take all the. Can you guys see my screen?
Yes, you're back.
Yes.
Yeah, I'm right here. So sorry.
Don't worry about it.
I wish everybody like you. Okay. We were on here. Okay, we're good? Beautiful. So 76, 20 years later, Dr. Benick and Halpern clearly stated that they found the risk of addiction of oxycodone greater than attributed to morphine. And we believe that oxycodone should not be used past initial phases of treatment for pain, which is, again, I still am against using it for any type of pain in ED and a discharge, but at least they're clearly stating in the hospital settings, maybe, but please don't send them home. Dr. Ramillard published a survey of 113 patients suffering from opioid use disorder, and they conducted a qualitative survey by assessing individual opioid attractiveness, desirability, and being a gateway drug to heroin. And results of the survey stated that those 113 patients, 62% of those clearly stated that oxycodone was the most desirable. 72% of respondents stated that oxycodone was the most addictive, and 78% of those stated that oxycodone was the gateway drug to their use of heroin. This is crazy. 62, 75, 78. That's a lot of percentages. So oxycodone, evil, evil, evil. And Dr. Whiteman and colleagues put together another review article describing abuse, liability, and likability of commonly prescribed opioids, in which oxycodone was significantly higher rated with respect to abuse liability, meaning reward, reinforcement, taken again, and likability. Same thing with respect to having more positive effect than negative effect. So oxycodone was more prominent with this respect than hydrocodone and morphine. So please say no to oxycodone when they need to. Hydrocodone usually comes in combination with acetaminophen known as Vicodin or Norco. It's a prodrug, which means it has to metabolize into something in order to achieve its analgesic effect and unfortunately euphorogenic. So two metabolites, one is pretty much non-active, nor hydrocodone. One is very active, which is hydromorphone. And we talked about hydromorphone already. So all analgesic properties and euphorogenic properties related to hydrocodone is due to hydromorphone conversion. And hydrocodone does cause reward, elation, and ultimately euphoria. What's so interesting about hydrocodone, it's a very short acting, but it kicks in very, very fast. And if you get it, hydrocodone and patient is susceptible to prone to the euphorogenic properties of it and like them much, they will be using medication very frequently, some between 2 to 3 hours in order to achieve this rewarding effect. And that's what sets them up on the path of self-destruction because they wanted to experience more and more of this euphoria and elation. So in my opinion, again, I would not use this as a first-line defense. I might still consider using it as a second because it has a lesser degree of euphoria and abuse liability than oxycodone, but I have something better for you. Hydromorphone, we talked about this, but this is oral hydromorphone, slightly different. Why? Because when you take hydromorphone, when people take hydromorphone orally, it has actually very slow onset of action. And because of it, studies related with respect to abuse, liability, and likability of commonly used opioids clearly stated that hydromorphone orally ingested was number 4 after a variety of oxycodone-containing formulary, hydrocodone, and methadone. Don't get me wrong, it's still abuse prone, very euphorogenic, but it just takes a while for him to kick in. Tramadol, or shall we say tramadol, that's the nemesis of mine that everybody should just forget about it. No matter if you in internal medicine, surgery, any specialty that had to do something with people and you consider prescribing opioids, this is the one you should just put big no and never ever prescribe it. There are lots of things. There's a lecture within itself to talk about tramadol. I'll be very quick and succinct. It's a prodrug, has one active metabolite and one this methyl tramadol, which is about 600 times more potent from analgesic perspective than parental compound, and it's about 1,000 times more euphoric. or euphorogenic, and studies on healthy volunteers or patients without an opioid use disorder, aka opioid naive, clearly stated that rate of positive reinforcement that they get from tramadol is extremely high. And that's why, if you remember the graph I showed a few minutes earlier, tramadol use and misuse is on the rise. On a side note, in the United States, oxycodone and oxycodone-containing formulary out of prescription opioids still the number one responsible for opioid death and overdose. Worldwide, tramadol is the most addictive opioids of all times. So just on a side note. Codeine, this medication should never seen the light because it's a crappiest analgesic on the market. People say for the cough, it does really work, but it really makes you constipated, and it has a whole host of associated symptoms related to being an opioid. On a side note, again, I'm not going to go into details because I'm pretty much sure some people will stop me. Enough of this already. Remember, genetic variability clearly separates us into three groups. Most of us right now on the call probably all rapid or extensive metabolizer, which means we convert codeine to morphine at predictable rate and we'll be just fine. Maybe paucity of us, maybe nobody, is a poor metabolizer, which means I can give a gallon of codeine, you will never have any pain relief, and you have any side effects. But there's a subset of us that can be ultra-rapid metabolizer, which means most of the codeine will get metabolized to morphine, and that's where the problem sits. And that's how we overdose and die. People do get high with codeine, primarily from the cough syrups. That's why American Academy of Pediatrics actually banned this medication for initially children less than 7 years of age, and now children or adolescent or teenager till 17. But you can still get high because of an opioid. The only difference is therapeutic dosing regimen for codeine, it's somewhere between 30 to 60 milligrams per dose, 3-4 times a day. Opioid naive can start with 30. In order for people to get high, dose needs to be somewhere between 800 to 1200 milligrams. Just listen to this, 1200 milligrams of codeine to get high. If I take this medication right now, you would not see me again. Some of you might be happy about it, but frankly, it's a hell of a large dose. And the fact is, I will definitely have respiratory depression and get that naloxone ready. So please do not use codeine for any type of indication. It's just miserable drug and prone to disaster. If I stop right here, you're going to tell me, you know what? You just made my life or our life miserable. You pretty much killed everything. Hydromorphone is evil. Fentanyl, what we need to be very careful about. And then you just bashed oxycodone, hydrocodone, tramadol, codeine. Is there anything left for us besides M&M? I said, sure. For the past 7 years of my personal practice, I've been utilizing morphine sulfate immediate release tablets as my go-one opioid of choice when I've determined if patient benefits from oral opioid. Why? Well, first of all, what there? It can come as a tablet, can come as a liquid, can come as a suppository, which primarily reserved for patients with intractable pain who cannot swallow, dysphagia, or cancer. But let's just stick to a liquid or a tablet. And the reason being morphine sulfate is so good because it has a lesser degree of abuse, liability, and likability, aka it's less euphoria prone. Less euphoric, less misuse, or less street value. Less street value, less diversion. Less diversion, less potential for buying it from the street, overdosing, and dying. So almost everybody win. But the most important thing is when analgesic efficacy of morphine sulfate immediate release was compared to oxycodone and hydrocodone, and remember, we're still honoring this analgesic conversion, there were no difference whatsoever. And that is why this is my opioid of choice. If I put balance between analgesic efficacy and potential to cause euphoria, this is a clear winner in my book. And again, I've been using it for years, and I've yet here to tell you, having a patient coming back and said medication did not work. When morphine sulfate immediate release was compared to all other opioids with respect to potential to be addictive. And once again, I just want to reiterate myself, all opioids are addictive, even morphine sulfate immediate release, taken for a long period of time and a larger doses, but it rated number 9 after all various preparation of oxycodone, hydrocodone, hydromorphine. Remember I told you, find the lesser evil of the all evils. And in my book, that would be it. Still depressing, right? But see on the bottom, there's a tiny little candle. There's a light. There is a light. And I'm going to make it very, very easy for those of you who practice in emergency medicine, who are about to practice, who practice not emergency medicine, but still in areas that you're taking care of patients, any specialties. Once for our colleagues from internal medicine, just remember that it's equally applicable to you than to all of us in emergency medicine. When it comes to opioid prescribing in the ED, I have a very simple algorithm. Morphine sulfate for the win, parenterally, morphine sulfate immediate release for the win orally. If patients cannot tolerate adverse effect related to morphine. Remember, dysphoria is very prominent, or patient require much higher doses and they cannot have dose they cannot tolerate because of it. Fentanyl to the rescue in the setting of parental morphine, and still breaks my heart to admit this, but I would probably settle for hydrocodone, 2-3 days tops of hydrocodone. And remember, no tramadol, definitely no codeine, no definitely tramadol, and no hydromorphone, and no oxycodone. So once again, parental morphine, fentanyl to the rescue as a substitute, morphine sulfate immediate release as an oral opioid of choice, and hydrocodone to the rescue substitute if we need to. See, told you at the end it's going to be very easy and straightforward. Just remember this picture: one drug, morphine, 2 formulary. And I'm going to wrap it up this with my favorite part, slightly philosophical, but this is very, very important. At this point, and most of us, including myself, still we're practicing pain management in the ED and outside of ED in a very transactional way. What do I mean by transactional? Government tells us what to do, trickles down to the state, state trickles down to the department, to the hospital, hospital to the department. We're a given set of guidelines, mandates, moratorium, memorandum, anything we give it to you, and what we respect in return to follow them. It's a transaction. You're given something, you're given something in return. No brains involved, no thinking. We were told to do something, let's do it. I hate this. I really do, and I hope you all do. So what I'm planning on changing this right now, right here with you. God, I wish I could get to see you all, and then I would make very inappropriate gesture in the sense that let's do this differently. So I'm turning or converting transactional way of treating pain to transformative. And I'm introducing you to 30-second rule. And more importantly, I'm introducing to Sergey Motov Bull's diagram when it comes to 30-second rule. 3 questions, 7 seconds per question, 3 for answer. Why do you think 7 seconds? Well, average attention span for human beings is about 11 seconds. You want to take a guess, average attention span for emergency room physician? 3. So let's settle for 7. Here's how it goes. Anytime, starting tonight, tomorrow, day after tomorrow, in a few years when you're ready to get to residency, graduate from residency, anytime you're about to do something medically related, specifically taking care of patients in pain, I wanted you to ask yourself 3 questions. Question number 1, why am I prescribing this particular opioid? See, I didn't say why you're prescribing opioid. I trust you. You've made your judgment. You believe the benefits of giving an opioid outweigh the risks. Perfect. Now the question becomes, why are you prescribing this particular opioid? If you have a good answer, go to the question number 2. If you don't have an answer, especially my favorite, well, attending tell me to do so. Don't. Stop. Talk to your attending, reconsider, because that might not be the best option. With all due respect to my fellow colleagues, but that's how it is. Question number 2, do I understand the risks I subject my patient by prescribing this particular opioid? Once again, I'm not challenging your desire to prescribe an opioid. I'm just challenging the concept of whether or not you fully understand the risks you subject your patient by prescribing a particular opioid. You have a good answer, move forward to it. To question number 3, no good answer, go back. And the last question, will I take full responsibility for consequences of my prescribing? This is slightly more philosophical, and it's very less applicable to emergency medicine. A very good example. A patient comes in with a broken ankle. No, it's a bad example. Patient comes in with slightly less of a pathology that required an opioid, and patient was given prescription for oxycodone. It just so happened patient was actually very susceptible to euphoriogenic properties of oxycodone. And a year later, after that index visit in the ED, the Jew were the one who gave him this prescription. Patient was found in the alley with a needle in his forearm vein, syringe full of heroin, and patient died. Will you take responsibility for consequence of your prescribing? You might never know that this patient died, but let's just say he did. You would never know. But I just want you to remember in the back of your head, sometimes there's a much more implication to your prescribing in the long run than in the short run. So, transformative experience. Why are you prescribing this opioid? Do you understand the risks? And most importantly, will you accept the consequence of your prescribing? And if you're ready, I'm inviting you to join me and let's the transformation begin. Thank you so much. And once again, I am so profusely sorry for having this IT fiasco, and I hope you will forgive me. So I'm going to stop sharing the screen for now. And Zoe, Jordan.
Thank you so much. That was great. And no worries about the little break in the presentation.
Little perk.
Happens. So I don't see any questions right now, but I have a question for you. And you might have kind of touched on this, but what started like what spiked your interest in really pain management and looking into all of these medications a little further than most of us might, and just being so proactive about it?
Wonderful question. So I remember vividly that period. I will not tell you day and time because it'll be very creepy. I was a second year emergency medicine residence, and I had a patient once who was having some mild pain, and I was going with my favorite ibuprofen and maybe a little acetaminophen. And my attendant said, "What are you doing?" I said, "Trying to take care of the patient." He goes, "No, no, no, just give him Percocet." So why would you give him Percocet? He doesn't need it. "Oh, no, 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 just give him Percocet and give him one refill. Give him 30 perks, one refill, and send him home." I said, "Why?" He said, "Would you stop asking me why? I told you to give him Percocet and just go away. Why? What is this? There's next patient waiting to be seen." Usual thing. I'm talking about 15, 17 years ago, slightly different at that time. And I didn't like it much. And then I realized, I am I'm an international medical graduate. I did not get any formal training in pain in my medical school. And I can attest to the fact that American medical students don't get pain indication either. So we're all in the same boat at the level I want them to have. And I took upon myself to read up, to educate, and I've reached out experts in respected field in pain management. And one thing led to another. I got invited to meet some people. I got invited to research and start writing certain things. And 16 years later, here I am. Have an amazing opportunity to meet you all and have a discussion of euphorogenic property of opioids. See?
Yeah, and it's so important. We really don't question our superiors that often. So this has definitely taught me how to appropriately go about that conversation and be informed and be able to kind of take that role on like you are.
Or just blame me. Just tell me, I was at the webinar and Dr. Motov said me to do so. So just any problem, just reach out to him. That's his email and Twitter handle.
I have a question for you as well. So, with my previous experience working in an ED, and I know like in some states they may have this and some they may not, but does the state of New York have like a prescription monitoring program where you guys can kind of see if they had a recent prescription of like an opioid or anything like that to be able to check?
Yes. Oh, it's a beautiful question, Jordan. And Zoe, thank you so much for doing this as well. Just bring all the good memories to it. I stop in the prescription drug monitoring program in New York called iStop. I personally like Doctor First, which is better because it gives you almost a year worth of medication. You can take a look at it. But I want to take this opportunity, if I have, for just reiterate that prescription drug monitoring program should not be considered as a punitive measure. I use this to elucidate not rather the opioids, but may elucidate the dose of an opioid and see whether or not it's above the threshold that can be potentially detrimental to a patient. I'll look at this system to elucidate again or evaluate whether or not there's a potential dangerous combination. Let's say opioids and benzodiazepines, right? Opioids are sedative hypnotics, opioids and gabapentins, which make overdose much more palatable and much more dangerous. And lastly, judging by the list and frequent visits, I may identify patients who exhibit evidence of opioid dependence and frankly opioid use disorder, and I can initiate a conversation. See, I'm challenging to help the patient rather than punish them. I'm not bringing this paper telling, look, you've been there and there and there, you're not getting any opioids, get out. And patient has a broken femur. It just doesn't sit well with me, right?
Right.
So you take this data and you bring to the patient and you have a conversation. Maybe they need help. Once more, they need education because nobody ever told them that. And tell them, you're taking this, it's a little wrong. Let's figure out how we can help you. So I stop in New York or Doctor First.
Okay. And it's not like a required thing that you guys have to do if you do send them home with a prescription for opioids?
Well, look, it's required. It's almost mandated everyone else, but there's stipulation to it. If you do it for less than 3 days or 4 days, look, personally, you should be looking at it. I mean, if you consider prescribing opioids, and it's hard sometimes to trust the patient if you should, but if you're concerned by the particular patient, just go to Doctor First or I stop and take a look at the prescription list and make sure there's nothing dangerous about it. But I believe, frankly, for out of emergency department, because it's less than 7 days, I do personally 3 to 4 days. Women not need to do this.
Right. Okay. Thank you.
My pleasure. Do we have actually people in webinar? Do we have attendance?
We have an attendee.
Yay!
Another question for you. I was going to ask you about your go-to analgesic, but I think we got a taste of that at the end. Your kind of order of things. Are you doing? I know you've been doing this for like 16 years, but are you doing any research currently?
I am.
Okay. What are you doing?
So my actual passion is, in addition to safer and more judicious use of opioids, is non-opioid analgesia, and I have this particular proclivity to study ketamine. Ketamine has been my greatest interest and passion and interest. Yeah, like Jordan is nodding. So my team and myself and my fellow colleagues, we did a fair amount of research on ketamine by using it intravenously, as a push dose, as a drip dose, by using intravenously, intranasally. And now recently we've been using ketamine via nebulization device. So this is my research currently, nebulized ketamine for pain.
I've seen, this is a little random, but it comes up on my TikTok for some reason, people getting infusions of ketamine for like refractory depression.
Yeah.
Okay.
Oh, you can get very high with ketamine for depression. Ketamine is very high prone medication. You can get those vivid dreams and you can reset your brains and everything else, and looks like
Wow.
depression is going away. You remember, you're going to a happy place. And that's
Yeah.
what ketamine does. Yep.
That was very
Yeah,
interesting.
it's definitely there.
Yeah, it's definitely being used more now for like a bunch of different things than what previously I think was indicated for.
Totally. It's a very unique drug, and the potential is still untapped because we're trying to learn and to figure out what's the actual mechanism of action and what can be used. And traditionally used for anesthesia and sedation and induction of sedation for patients in ED primarily who are undergoing intubation, or we use for procedural sedation where we need to put somebody transiently to sleep to perform a procedure. But now it's expanded to world of psychiatry. And recently I came across the papers. Now ketamine has been considered to use for alcohol use disorder, for either treated or even alcohol withdrawal syndrome. So yeah, indications are being expanded.
That's
but I'm
cool.
still ketamine in pain. That's my niche and that's my passion.
Another thing too that I saw previously is like, do you guys have like a certain type of like so I've actually seen like capsaicin being used for like a topical hopeful treatment for pain. Is that something that you guys still try to use, or if you try to stay away from opioids, or is there
So capsaicin has been used in the ED, so it can be used for neuropathic pain. In a dosing, traditional dosing, it's fairly benign. The only thing is I need to warn everybody, it's made out of red hot chili pepper. So when you apply capsaicin, try not to touch any mucosal membrane. We're talking about eyes, nose, throat, and genitals. Then you're going to be in so much trouble. Not enough opioid ketamine to help you to get rid of this pain. It really burns a lot. But the fact is, there are indications for capsaicin that we use in our emergency department and in some emergency department across the country and the world is cannabis hyperemesis syndrome. Due to mechanism, I'm not going to really bore anybody, but there is some mechanistic explanation to it. By rubbing capsaicin or applying capsaicin to abdominal wall, you reduces the urge to pain, and then somehow the urge to vomit, it disappears. So that's the indication it's been used in already. Topical capsaicin, rubbing on the belly for patient presented with the cannabis-induced hyperemesis syndrome. Yeah.
That's pretty cool.
Wow. Yeah.
I remember like before starting medical school, seeing it used. It was like a newer thing they were starting to use, and I didn't know if it was still something that you guys like try or if it was kind of proven otherwise. But great alternative.
It's there. I just love your genuine facial expression. It's so rewarding. Like, whoa, I learned something new today. This is good.
Learned a lot today, actually.
Just remember the historical perspective, those Sumerians, right? This is what gets you going.
Wow. Let me see. Don't think we have any questions. So probably start closing things up. Thank you again, Dr. Motov, for coming tonight. Very educational. I learned a lot. And definitely will be trying to apply this in my future practice and even as a med student now, talking to my seniors. For the attendees, we're always interested in your feedback. There's a little survey at the end of the webinar. If you would please fill that out and stay tuned for our next upcoming sessions.
Just please disregard the IT fiasco because that should not.
We might be able to edit that out. I'm not sure.
It's okay. It's okay. I'm fine.
No worries.
But the reason being, I gotta tell you, I'm so thankful, and frankly, I can do this for 1,000 people, and I can do this for 2 or 3 or 4. To me, it doesn't matter the audience, as long as I have you guys and your super fertile soul for me to do this, because I know you're going to take the message and you're going to
Yeah,
pass it to your colleagues and generation. And that's my biggest achievement. If I can pass it to you and convey the message. So I feel like it was very good. And I've enjoyed it immensely to being with you.
absolutely. And we're gonna have it posted on the website too, so many more people to come can learn from you.
Cool. Thank you. Thank you. And again, I'll always say anything for the future, if you need outside of AAEM and everything else, if there's a need for a smaller group for your fellow colleagues and everything else, just let me know. I'll do it again and again and again. I'm very keen on the fact, and I have a very soft spot for medical students. I gotta tell you a secret. My greatest dream is to get to medical school and to teach medical students pain management from MS1 to MS4 longitudinally. And I believe that would be my greatest contribution to society. So we'll see how that goes.
I think that would be great to incorporate into our curriculum, because you learn about the opioids and everything, but you also don't learn about like the downside of it and,
Right.
maybe some alternatives. So I think that would be great.
Awesome. So again, ladies, it's been a pleasure meeting you. Thank you so much
Thank you so
for the
much.
Thank
opportunity.
you.
I'm glad you enjoyed it. Thank you so much.
Thank you. Have a good rest of your night.
Have a good rest of the night, you too.
Let me stop the recording.